Ex-Vivo ureteroscopy during machine perfusion preservation for removal of renal stones. Our technique, experience, and results. Our technique begins with the kidney on machine perfusion preservation, on pump. A sterile field is set up and the distal ureter is spatulated in order to facilitate placement of a ureteral access sheath. Our preference is to use a 10 French 12 French sheath. A wire can help with sheath placement, but fluoroscopy is not used. This donor did not have preoperative CT images available, but the report documented several punctate stones. On piloscopy, there was a significant amount of sand that was thought to be able to pass down the ureter after transplant. However, there were two 1 mm stones that were removed via the basket. Postoperatively, the patient was maintained on a sodium bicarb drip by the transplant nephrology team due to metabolic acidosis, and this may have helped to alkalize the urine to help clear the debris as well. This CT scan demonstrates another case. This donor has the right kidney with several small 2 to 3 mm stones, while the left kidney has several punctate stones and a 7 mm lower pulse stone. The following clips will show the case of the donor right kidney. The left kidney was also transplanted at our center several hours later and did require laser lithotripsy for stone removal. Flexible ureteroscopy and piloscopy was performed, which confirmed the findings from the CT scan. All visible stones were removed via the basket. Once final piloscopy was performed, the ureteral access sheath and the ureteroscope are removed under direct vision, and the kidney is returned to the transplant team for back table preparation. While removing renal stones prior to transplant has been well documented, there are varying methods, including semi-rigid ureteroscopy, flexible ureteroscopy, as well as pilotomy. There is only one documented case of this being performed on pump, with the majority of cases occurring during ice bath. We have now performed this technique on 5 total kidneys prior to transplantation. All patients now have functioning grafts and are no longer dialysis dependent. No infectious or stone-related complications have been documented. Follow-up imaging has been at the discretion of the transplant team, with all 5 undergoing post-transplant graft ultrasound and 2 patients undergoing abdominal CT, but no nephrolithiasis or hydronephrosis has been documented. There are about 90,000 people currently waiting for a kidney transplant in the United States. The disparity between the number of patients waiting for kidney transplantation and the limited supply of kidney grafts leads to high mortality on the waitlist and long waiting time. Due to the shortage of deceased donor kidneys, transplant centers attempt to maximize organ utilization, including grafts from donors that have kidney stones. Ex-Vivo ureteroscopy and stone removal in a donor kidney prior to transplantation can decrease the risk of an acute stone event post-transplantation. This is certainly beneficial to both the recipient and the endourologist, as treatment of transplant renal and ureteral stones is quite challenging, and the immunocompromised recipient is at risk of infection with subsequent procedures. The advantage of doing ex-vivo ureteroscopy under machine perfusion preservation is that we can maintain superior preservation modality until the end of preservation time. This can also be performed at any time prior to transplant without affecting the timing of the transplant. Besides that, the continuous flow of perfusate fluid through the ureter after removal of stones can help eliminate some of the stone dust before the kidney is implanted.